Before we get started with the talk, I just wanted to place some of these questions into your mind. For example, which of the following is the most correct regarding nocturia in the elderly? Just go over those answers and think of a potential answer for later on. Which of the following is most correct regarding the syndrome of nocturnal polyuria? And you can just skim those quickly. All of the following are causes of nocturnal polyuria except. Okay, so I'm going to give you a little different view of nocturia in a non-urological way. The prevalence is around 70% of all adults experience nocturia. It's the most common type of lower urinary tract symptom, and it is rated as the most bothersome, and the prevalence increases with age. Nocturia can be considered a normal part of aging, a neurologic problem, just another component of LUTS. Maybe it's a symptom of BPH or bladder outlet obstruction in women. Maybe it's a symptom of OAB, and therefore all the treatments are urological. After all, it's nothing more than a nuisance. This is completely wrong. Nocturia in and of itself causes sleep deprivation, and sleep deprivation is associated with a myriad of illnesses, all of which can cause serious morbidity and mortality, and in turn perpetuate nocturia. So it actually can be a vicious cycle. Nocturia disrupts sleep, and in doing so causes chronic fatigue, depression, endocrinological disturbances, can predispose people to trauma, is a cause of hypertension and mortality. Nocturia times 2 can be associated with hip fractures in both men and women, and is a single risk factor for this to occur. Another group, Fenn et al., noted that nocturia in and of itself increases anyone's mortality by 22%. If an individual has 3 or more episodes of nocturia, this increases the mortality rate by 46%. Sleep disturbances in and of themselves increase blood pressure. Normally, all of us have a 10% dip in our blood pressure overnight. If our sleep is impaired in any way, either by quantity or quality, we do not enjoy this normal dipping, and this normal dipping is associated with hypertension during the day. Nocturnal hypertension has also been predictive in studies for cardiovascular morbidity and mortality. This is a complicated graph, but I really like it. I think it's a really cool way to display data. This is from a sleep medicine paper looking at factors which will increase one's risk for hypertension. And as you can see, in the lower part of this is a really wimpy laser. This area here, we can see risk factors that enhance or increase the risk of hypertension. At the bottom, for example, we have alcohol consumption. This gives people a 1.5 risk ratio for hypertension. In the top quadrant, you could see type 2 diabetes and hypercholesterolemia. These increase the risk of hypertension twofold. So look on the quadrant from noon to 3 o'clock. Nocturia also has this effect, and the number of voids per night increases this risk, so that when you're up to 4 voids per night, you've already increased your risk by 1.5 or by 50% for hypertension. Is nocturia a cause of something else, or is it just a marker for an underlying disease? And I would submit to you that it probably is more of a marker, and we should take it seriously. I already said around 70% of adults over 40 suffer from nocturia, but most of it, 88% indeed, is nocturnal polyuria. So every time we have a patient that we call as urologists nocturia, what we really should be thinking is nocturnal polyuria, and realize that the urological conditions overlap in a very small number. So you may more often encounter nocturnal polyuria when you're looking at a urological condition, but overall, the problem is nocturnal polyuria. And it's dangerous to equate nocturia just with LUTS, in men or women. Here's a patient I saw who had tried every alpha blocker over 2 years. He kept seeing different urologists, primary care doctors as well, and he just got the whole gambit of alpha blockers, and he just continued to worsen over 2 years. And he only had hypertension as his past medical history. So what else would you want to know in someone like him? Just pretty basic. So that's common. He has no pedal edema, interestingly, and his urine is negative. So those are pretty simple things to rule out. But the most important thing with anyone who has any type of LUTS, but especially in this setting, is the fluid diary. And unlike Dr. Payne, who is much kinder to his patients, I always ask for a 48-hour diary because I want to have some, corroboration of what's going on. And as you all know, and as indicated by the ICS definition, nocturia is any void occurring after one goes to bed. And if you measure the volume of urine, it has to include the first void of the morning. And this would represent all the volume that is produced while the person is sleeping or recumbent. In this man, you can see his bladder capacities are pretty normal, but you could see there's an overall, just by eyeballing this, huge volume. So perhaps we should even consider that he has polyuria, like a global polyuria. So when we do the NPI calculation, you take the nocturnal volume and you divide it by the 24-hour total, and you can see he's nearly 3 liters. If we were to do a calculation per his kilogram, he nearly does meet that 24-hour or global polyuria. But in his case, anyway, the NPI is 0.565. What is the normal? 0.33. But I said he's 64. So if you're under 64, it's 0.20. So that's even more impressive. What about the patient with OAB? This is a typical older lady you might see. She has nocturia. She's diabetic. She has Parkinson's. She's depressed, and she's married. What else should we find out about this woman? Yeah, Dr. Payne thinks I put the married in there after depressed for some reason. But anyway, what else do we need to know about this patient? Nocturia. Does she have insomnia? Is she a light sleeper? Or is she really waking up because she has an urge to void? This is paramount. So many people confuse this, and I've sometimes had to ask the question 3 different ways to get the right answer that, in fact, they do not have voiding problems at night, and indeed the fluid diary corroborates this later. She's diabetic. How is her glycemic control? When was the last time she had hemoglobin A1C? What is her fasting glucose level? What is she doing to manage it? Has there been weight change or change in medication since she had that diagnosis? Parkinson's. Well, with certain neurological conditions like Parkinson's and Alzheimer's, there's a diurnal variation in the ADH secretion, so it isn't occurring at night anymore. So this messes up these people's circadian rhythm. But also, Parkinson's patients have, in urology, they often have a neurogenic bladder and usually manifests as DHIC or detrusor hyperreflexy with impaired contractility. So what if she has that or some other form of bladder hyperactivity? She's depressed. Is this a primary problem or a secondary problem? Is her depression causing her to not sleep well? And some people theorize can cause some degree of nocturia. Or is this secondary because she is so sleep deprived? And what medications is she using that could actually be exacerbating or causing the nocturia? And what about her partner's health? It's interesting how much we don't take into account for any medical condition. We usually always say, oh, if we're dealing with sexual dysfunction, it's a couple's disease. But I would submit to you again that there's a lot of issues in our healthcare that require a couple's approach. So here's her voiding diary. And right off the bat, I think what we can all see is that she has a small bladder capacity. And all those things we talked about in the previous slide, could she have a diabetic cystopathy? Is this a manifestation of a Parkinson's neurogenic bladder with a small capacity? Is this what's going on? But then we look at the nighttime. So on top of a bladder problem, she likely has nocturnal polyuria as well. So if you take the formula, her NPI is 0.501. And this has to be taken care of in the same way and maybe even with greater urgency because her sleep will impact all other aspects of her health. So what causes nocturia? The urologic causes we all know. You can just look over that list quickly. I would say to you that last one, bladder neoplasm, I found that in a text, so I'm putting it in, but I have to tell you it'd be utterly incredible that a person would only have nighttime symptoms and that would be the underlying diagnosis. And I'm reminded years ago of a letter I wrote to the AUA because during the plenary session for nocturnal polyuria, the moderator asked the panelists, well, what's the first thing you would do in this patient with a negative urine, by the way? And the urologist said, the first thing that should be done is a cystoscopy. And I just wrote a letter and said, that person should never be in a plenary session again. What about the causes of non-urologic causes of nocturia? Well, I would say we should change that phrasing altogether. If there's a non-urologic cause for nocturia, it's nocturnal polyuria, by definition. The obvious ones, of course, are chronic heart failure, CHF, venous insufficiency, lymphatic insufficiency, diabetes. But rare disorders, as I alluded to before, would be the neurological diseases. We often think that maybe they have a neurological issue affecting the bladder, but in fact it is a hormonal problem. And in some of these instances, it can even affect the ANP, or the atrial natriuretic peptide. And in renal disease, we know that the patients have a poor concentration of urine, and this is magnified at night or more bothersome at night. So the easy ones to address in our clinic, interstitial edema formation, you just notice or you ask the patient about ankle, foot swelling. These are caused by congestive heart failure, venous or lymphatic insufficiency, and when that patient is recumbent, all of that third spacing mobilizes, the kidney perceives a larger volume and produces more urine. The way we can intervene first is by restricting fluids in the evening. I'm sure we've all recommended this to our patients. Some can use support stockings, but as I was telling Dr. Payne the other day, I'm like, have you ever tried to put support stockings on? I'll tell you, if I was older, because I used them during my pregnancy, if I had to use them when I'm older, I'd probably just leave them on. I mean, they're just horrific. So that's a pretty large order to recommend to patients, and then of course you just tell them to use a bidet. Leg elevation is another remedy. Afternoon naps, I've had success with that, just actually listening to a patient say, well, when I take my nap, I'm awakened from my nap. I'd like to sleep longer in my nap, but I have to pee. So obviously this is therapeutic for them to get some of that fluid off before they actually retire for the night. And then the controversy of whether or not we should use afternoon diuretics. My rule is that if the patient is already taking a diuretic for these conditions and they're taking it in the morning, then why not try it at 4 p.m.? It does, though, affect their social life, and that should be recommended sensitively. Sleep apnea. Sleep apnea is huge. It's growing in prevalence. Most of the literature cites a single-digit prevalence, like maybe 7% overall, but according to the American Association of Sleep Medicine, it may be as high as 26% of adults over the age of 30. And remember that no matter what the number is, 80% of them are undiagnosed. And ladies can have it too. Nocturia is independently associated with sleep-disordered breathing, and it also correlates to the severity of the nocturia as well. Intermittent hypoxia, sympathetic hyperactivity, and variation in the intrathoracic pressure during these breathing or unbreathing episodes lead to increased secretion of natriuretic hormone. Another way of looking at it is that the hypoxia and hypercapnia that occurred during the apneic period cause vagal bradycardia, pulmonary hypertension, tachycardia, cardiac overload, and this leads to a secretion in the atrial natriuretic peptide. And I didn't know this until I did this paper or did this lecture, that it also suppresses the AVP. I thought it was purely an ANP phenomenon. In addition to that, the apnea also can provoke blood pressure. This hypoxia causes sympathetic outflow from the kidney, and it activates the renin-angiotensin system, and not only causes the excess of angiotensin, but also of aldosterone. This also contributes to that preventing of the dipping of the blood pressure that I spoke about earlier, and this is sometimes referred to as the non-dipping phenotype. So with sleep apnea, you can be such a hero. You send them for a sleep study, but you prepare them for the fact that they're going to need CPAP. This is one of those times where I'm not really hardcore with the coaching for diet and exercise and other lifestyle modification, because these folks are so sleep deprived. It's so hard to just muster up that motivation. But once the CPAP is on board, these patients describe coming back to life. They describe something akin to like a renaissance. And that's the time to get the diet and exercise involved and other modifications that will help them to hopefully, solve the problem and maybe not even need the CPAP, but a lot of people need it for life. And I'd also like to point out to you, we have friends who are kind of our body types and they have CPAP. So it is not only a disease to consider in people who are overweight, but it is a problem for anybody over the age of 30 or 40. So still keep a high incidence of suspicion, or a high index of suspicion when you see patients who may have this problem. What about the patients who are lacking antidiuretic hormone at night? And by definition, this may be most of the patients who have the syndrome of nocturnal polyuria. I highlighted in yellow the insufficiency at night with the authors Asplund and Aberg because they are still cited for this connection and the fact that this is probably what keeps everything going, and it may be its own disease process. It doesn't necessarily have to be in that list that I showed you. It could just be that with aging alone, they have this deficiency. And these other factors do affect the deficiency. Medications, alcohol, caffeine, day-night cycle being disrupted, people who do shift work, for example, electrolyte imbalances, and if there's a problem with the renal receptor, this can happen either as an autoimmune disorder or as the result of medications. The one we're most familiar with is lithium. So in this case, you can't use DDAVP for treatment. In those rare instances, things like amiloride have to be used. So when we treat the deficiency, which I admit I've been afraid to do because my training was always that these patients are older, they're going to have hyponatremia, and hyponatremia is fatal. Well, this isn't true. The meta-analysis done in 2012 proves that it's efficacious and safe, and this was done with the studies that I cite below. When I looked at these studies, they all basically used the same recipe, which should reassure us very much. So they have a responder test initially. There's a washout period, and then they randomize the patients, only those who are responders. Greater than 90% of the responders would stay on the treatment for as long as the study went on, and in some cases it was up to 12 months. The fact is, in all the studies, men tolerate higher doses. That's a fact. Unfortunately, that doesn't mean that the men have a greater result. They have a more of a moderate response even at higher doses. The good news for women is that the tiniest of doses or moderate doses work very well, and in fact, the goal of the study, in many of the studies, was that at least 50% of the participants would have a 50% reduction in the volume, and this was found. The decreased volume certainly equated to increases in sleep, in some instances an overall 60 extra minutes of sleep per night, which means a lot, especially when we're not talking about disruption. So remember, with sleep and sleep hygiene, it's not only the number of hours we get, but it's the number of uninterrupted minutes that we get. Serious adverse effects had nothing to do with the medication. This was so ironic, and I read this over and over again. And oftentimes, the placebo arm reported more adverse effects as well, which just corroborates this fact. Hyponatremia was reported in 3 to 12% of the studies, but rarely was symptomatic. So the key is the monitoring. And again, all of these authors used basically the same recipe, just using a certain change in the actual drug. And the latest one from Weiss, he was using a disintegratable sublingual form, which was very easy for people to take. So my recommendation for prescribing the ADH is to use whichever is comfortable for you or your patient, but starting at the lowest dose, 25 micrograms, and going up to 100. Monitoring the sodium on a very regular basis, as well as adverse effects, but determine early on whether the patient is a responder or not by following them with a fluid diary. They usually check the fluid diary within 2 weeks of starting the medication, and if they're not going to respond, then there's no need to go through all of this hassle. So at this point, does anyone have any questions or anything I need to clarify? Okay, so I'm going to return to the questions that I introduced at the beginning. And those I borrowed from Dean Kajuba, who is a nephrologist at UCLA. So I may not necessarily agree with all of his answers. But anyway, I'm very grateful because I thought, oh, these are excellent. I'm going to steal them. So which of the following is most correct regarding nocturia in the elderly? The majority are caused by urologic issues. Hopefully you all say false. Okay. It disrupts quality of life but has no effects on morbidity or mortality. No. False. Its prevalence increases to 80 to 90% in 80-year-olds. True. And chronic kidney disease is associated with decreased urine output. That is a trick question there, but it's the opposite. So the correct answer is C. Which of the following is most correct regarding syndrome of nocturnal polyuria? Oral loop diuretics taken 6 to 10 hours before recumbency reduce nocturnal urinary frequency. He says that's false. But I kind of do it, but I think what he means, and I tried to find the rationale for this, I think it's because it's the temptation to do in anyone. But I think you and I are thinking if we saw a patient with dependent edema, we would probably do this, and we wouldn't be wrong, I think. And I think it does help our patients. Nocturnal ADH secretion is decreased in all cases, and that's true because we're calling it the syndrome of nocturnal polyuria in the elderly, and it's true. All of them have impaired secretion of ADH. Oral desmopressin is both ineffective and potentially dangerous. We need to just take that out of our heads. And the CPAP may help sleep apnea but has no effect on nocturnal polyuria. And there are many studies to show that once you fix the problem, patients' urine volume and frequency go down. So answer is B. All of the following are causes of nocturnal polyuria. This one is pretty easy. All of them are except for D. Okay. So in summary, the history we should take, you're going to do a thorough history, but just the ones that touch on this issue. Is it poor sleep or is it just urinary urgency at night? Is it genuine nocturia? What about the sleep hygiene? What are these people doing before bedtime? What is their daily level? Is there a problem on the weekends? What is the alcohol caffeine consumption? And of course, the past medical history will give us clues as well into potential causes or risk for nocturia. The medications. Is this patient thirsty? Have they not been diagnosed with diabetes or diabetes insipidus? Has anyone ever commented about your snoring? That's always a great question to ask someone unless their bed partner is a sounder sleeper than they are. But that's always worth asking. And one time I had someone say, oh, that's right. I fell asleep on the couch and my teenage daughter the next day at breakfast told me that they got so scared because they thought I stopped breathing. That's a very good indication for a sleep study and to rule out sleep apnea. And edema. Are your ankles thinner in the morning? Sometimes you have to ask this question because we don't always get to see our patients later in the day. What if the patient is your 8 a.m. patient And what you'll need to do in some cases is untie the shoes and look, because there won't be any pitting edema at the ankle yet, but you'll see all the shoestring marks on the feet. So that's very important. On the exam, BMI and waist circumference, because this may come into play as we try to help people decrease their risk factors. The blood pressure should be measured, as this is an increased risk in a nocturia patient. Their cardiovascular exam, which you would do anyway. The feet and legs, as I already described. The urine, I just love looking at urine. So we look at the chemistry. Of course, we're going to check in these patients their specific gravity. If it's nocturnal polyuria, their specific gravity probably won't show dilution during the day. But if it does, that's something to keep in mind, and that may also go hand in hand with glycosuria. Either a newly diagnosed diabetic, that happens a lot in urology. A patient doesn't even know they're diabetic, and you're the one who makes the diagnosis because of the LUTs or supposed LUTs. And protein. And of course, we're going to look under the microscope, rule out a UTI, a suspicious sediment, something that could be affecting them. But I can't emphasize enough fluid diary, fluid diary, fluid diary. So in conclusion, assume it's polyuria until proven otherwise. So I think I would rather just eliminate nocturia altogether from our lexicon and just use that for specific rarer cases. Always use a fluid diary. And finally, make the diagnosis and make an impact. Diagnosing, for example, sleep apnea has been one of the most rewarding things that I've diagnosed in my practice. And people do literally come back to life. Thank you.